Hi all, my name is Sian Gadamu and I work for the Aspen Global Innovators Group. Thank you all for joining today's live Aspen Health for All conversation. These conversations are part of a larger effort housed at the aspenhealthforall.org that is amplifying the important work being done by leaders and innovators all over the world to address the disparities that have been amplified by COVID-19. Our aim is to focus on health equity and connect a range of experts working on the front lines of health around the world as we pivot to respond to the challenges of COVID-19. We are in search of common solutions and shared insights. And as the US reckons with a legacy of racial injustice and continued systematic oppression of Black lives, we want to take this moment to say that we will not tolerate violence and hatred against Black communities. Our global community stands tall with local leaders, collaborators, healers, and fellows who have long been beacons in this movement and whose voices and work are critical to reshaping a healthy and equitable health for all. Today, the Aspen Global Innovators Group is excited to host a conversation with Dr. Mohamed Aburawi, the founder of Speetar, a telehealth platform that links health professionals in the diaspora with patients in their home regions, and Dr. Wendy Matos, the Director of Telemedicine for Puerto Rico Science, Technology, and Research Trust. We're honored that Dr. Daniel Kraft will moderate today's session. Dr. Kraft is one of Aspen's inaugural Health Innovators Fellow. He is an innovator, entrepreneur, and innovator. Dr. Kraft has over 25 years of experience leading biomedical research and healthcare innovation. As a reminder, please feel free to ask questions throughout the session using the Q&A box. With that, let's get started. Over to you, Dr. Kraft.
Great. Thank you. Hello, everybody. As mentioned, I'm lucky to be part of the first group of fellows in the Aspen Health Innovators Fellowship. And I chair a program called Exponential Medicine, where we look at the convergence of technologies and their ability to reshape healthcare around the planet, and particularly to democratize access to care. And I'm really thrilled to be part of this conversation with Mohamed and Wendy as we look at lessons learned in telehealth, which is certainly at the convergence of technology, the lessons learned and where that can go into the future in the setting of COVID and beyond. And I wanted to start off by both meeting Wendy and Mohamed. We will start with Wendy, who's based in Puerto Rico, to share a little bit of her journey with telehealth in Puerto Rico, lessons from the storms and earthquakes and beyond. And then we'll switch over to Mohamed. So Wendy, welcome. Thanks for your great work. And I thought I'd start with maybe a couple of stories that you have in your experience and some of the lessons you've gleaned in telehealth over the last few years.
Yes, I have been working for 2 years in this area of telemedicine, and among those experiences, one is tourist. We have a telemedicine equipment in a pharmacy in the tourist area, and she came in for an evaluation of earache. And when we used the equipment, we found out that the earring was inside her ear canal. So that was immediately a referral to the emergency room. The other one is that we have a strict managed care environment capitated for everyone in Puerto Rico. And we found out a very old man that was having problems with his vision. And when the physician was working remotely with him, he found out that he also have a cancer lesion near the eye. So at the very end, the guy went to his primary care physician with the results of the evaluation, with the consultation appointments for ophthalmology and dermatology, and it was an excellent result for the guy. So this is here for stay.
And you mentioned, you've been through hurricanes and more there. Telemedicine isn't a panacea.
Hurricanes, earthquakes, Sahara, air layer, Zika, chikungunya, and there's a lot of other conditions. So I was mentioning that, or I would like to mention that the first time with the hurricanes, we were, unprotected, and everything fell down, the power, there was no water, no power or anything. But now the people are very powerful in their communities. They organized and they are voicing their claims. They are not letting the government go with anything but to help them. And in my opinion, telemedicine was the mechanism that this time during the pandemic, the people get continuity to their services and follow up. So first time, the physicians went to the communities. Now, the physicians are taking their appointment schedules and calling the patients. So I haven't seen too many deaths now as we saw during the hurricane that were 46,000.
And you mentioned one of the most
4,600 people.
And you mentioned earlier one of the most powerful approaches that you could use telemedicine to be proactive to do outreach rather than waiting for the problems to evolve. What do you see as sort of the challenges still in implementing that and aligning both the clinicians and the patients and the communities to use telehealth?
In my opinion, the barrier that we must remove is the payment. The interventions between primary care physicians and their patients versus the specialists and subspecialists and their patients are different. So for specialists, that is the one that in Puerto Rico, you have to wait almost 4 to 6 months to get an appointment with a specialist. So I think that we are ready to embrace this methodology. The only thing that I would look at very closely is the payment, because there are many funds, there are people, equipment is available. We're going through procurement processes, but the issue is the payment. Who's going to pay?
Exactly. Mohammed, welcome. You've certainly been working in a very different part of the world, probably some similar lessons. Maybe briefly describe your Speetar platform, what you've seen evolve, particularly in the setting of COVID, and maybe some lessons that you've learned.
Yeah, thanks, Daniel. It's a pleasure to be here with you and Wendy. So Speetar is a telemedicine platform that was developed back in 2016 and currently in operation in Libya. And the idea is we connect patients in post-conflict countries and low-resource settings, launching from Libya, with physicians who speak their language and understand their culture, whether they're within their country or abroad. And this was basically started from what I saw in Libya. If you go in Libya, you'll see basically on the country's border, east and west, lines of ambulance cars, bumper to bumper, lined in front of gates. And if someone would see that in a picture, you would think that's a hospital or some kind of medical facility. But these are patients who are seeking care they couldn't find within their own countries. And what we're trying to do with telemedicine here is kind of to reverse that flow of patients going abroad and seeking care within their country. And we did a research back in 2016 with a small grant from MIT Sandbox Innovation Fund, just to look at why are these patients seeking care abroad. And we found that over 68% of these patients were looking for second opinion, follow-up care, and just in some cases, primary diagnosis. And these are all conditions and areas which we knew that we can address via telemedicine. So we tapped into the Libyan medical diaspora, and we created this network, and we started addressing some of these conditions. Obviously, after COVID struck Libya was not bubbled from what's going on globally, and telemedicine and our operations went into hyperdrive. We launched a new platform called Speetar COVID-19, and we had over 5,000 downloads in less than 2 weeks. And from these users, these were people who are being triaged, asking questions regarding their symptoms, and we were directing them to consultants who are directly affiliated with the Libyan National Center of Disease Control, just to tell them what are the next step they should take and whether they need to get tested and not. And if they need to get tested, where are the closest area, where are the closest centers that would be able to test them. And while doing this, we are collecting and centralizing all that data and providing it to inform local decision makers.
I think one of the fascinating parts of where telemedicine is going is it's sort of going beyond just the screen and having the communication eyeball to eyeball with the clinician, but adding in the data layers, or maybe a pulse oximeter or a digital stethoscope. Mohammed first, and then Wendy. Have you seen interesting examples of this integration of beyond the screen, and where do you think that might head into the future?
Absolutely, I think it's well said that telemedicine down the line is just going to be medicine, right? We're not going to have this notion of medicine and telemedicine. It's just going to be that's how medicine is practiced. And I think what we have seen in Libya. What we have seen globally, it was what was happening in Libya a few years ago, where telemedicine is actually based out of necessity, not just convenience. And that's, I think, what the rest of the world is coming to realize as well. And what you mentioned is exactly true. I think the power is in the data. The power is how to understand these kind of local population health trends, the industry dynamics. Where do you need to kind of focus your limited resource, especially within a context such as Libya? And without sufficient data, you're not able to do that. Now, with all these integrations and all these devices that will collect, I don't know, pulse, blood pressure, temperature, it's great, but you need to have that layer or that platform which you can integrate with. One of the challenges that we face in Libya is when we first started telemedicine, there was no EMR system that we can integrate with. So we had to develop our own. Again, that was a challenge, but it also was a benefit because we were able to create the first Libyan unified healthcare record, which we didn't need to kind of go across interoperability challenges that face other developed nations. So again, there's kind of challenges, but yet more opportunities.
And for Wendy, if you learned part of that adaptation, not just doing the outreach, is how do you educate the clinician, whether it's a nurse practitioner or a specialist, to use these platforms? And how do you sort of help not just improve their bedside manner, but now their webside manner, because it's a different form of practice?
Well, the first thing we did was to establish a collaborative agreement with the AARP, with the colleges, the several institutions, and the Department of Health. So once we had this team organized, we determined that we need to educate people. So we do educate physicians initially, and then we develop curriculum, and we are going to prepare community health workers to do telecare and to help in each one of the telemedicine clinics that we are having. I think that by the end of the year, we will be in a much better position and satisfied with results. On top of that, and speaking about the importance of data sharing and data, that was another thing that we are working with. So the Puerto Rico Science, Technology, and Research Trust is also implementing a hub where all the information related to telemed services will be cleared and analyzed in order to provide scientific information of outcomes and demonstrate that this is a need. It's not an option, and that we need to go with this the right way.
Right, and to demonstrate the change in outcomes, whether it's for primary care all the way to subspecialty care. Do you think that as we talked about, telemedicine will become medicine, digital health will become health, that, in Puerto Rico, the infrastructure still needs to be improved to layer in, whether it's 5G or even electricity in some components?
There are a lot of changes in the electricity area right now, but regarding the 5G, there is a big deployment of antennas all over the island, and I think that many people are going to be, the programs will benefit from that. Plus, there are a lot of money that is supporting this connectivity, and the government is working hard to make it happen. But technology is changing very fast. So we're pleased to have a lot of techies that are helping us. And for example, in COVID tracing, we are working very hard with the municipalities. And in my opinion, the difference is that in Puerto Rico, people are very warm, very, they like to collaborate, and they participate actively in the development of solving the needs. It's not the government, it's the people.
I was in Puerto Rico last fall with my Aspen fellows, and we visited several clinics, and you could feel the warmth, but also the sense of community. And obviously health is social, and telemedicine can make it more social for visits and beyond. But it's also, as you mentioned, at the government level, the regulators and the incentives need to be aligned. Maybe Mohamed first, and then to Wendy again. How do you see the regulators and the government and the policy enabling and getting in the way? And what would be on your wish list for your communities and maybe globally for what needs to help facilitate telehealth and to help with equity?
Yeah, I think it's a very important point that you kind of brought in, is the role of regulators. I think we saw what happened in the US with telemedicine and how many of the challenges were not technological. Like basically you're dealing with technology that's somewhat like Zoom, right? Or we had like Skype before. So the technology was already there, but many of it is regulated. Like where can physicians practice? Like practicing across state line, and in global context, practicing across like country borders, right? So in Libya, we had that challenge. Can physicians who are abroad practice and see patients within Libya? And the way that we went about it is we are interacting with Libyan physicians. So these are physicians who are already like trained and studied in Libya, but went abroad for further training. So already registered with the local medical syndicate, and they were allowed to practice. But again, so one of the things that our team is doing is helping working with the health ministry to craft Libya's first telemedicine guidelines, which is going to be a playbook on what can you do and what not, and what are the liability issues and limitations of telemedicine. Because again, you want somewhat of a regulatory context, especially when operating in a developing country where the technology kind of came before the regulation. But I think on a wish list, I would definitely would love to see these kind of regulatory hurdles being kind of dismantled, especially when it comes to a global context, because many times it's just it's more of a lobbying and market dynamics, not allowing physicians abroad to practice within the country, rather than actual medical sense, if you want to say, because usually physicians are well trained. So if they can go through a simple licensing, they will allow to see patients even not within their own countries. And this will I think will even the distribution of physicians, because again, we see how in many countries and areas, even within Libya, there's a high number of physicians compared to other areas. And the only way to even that is via telemedicine.
And you also have quite a challenge there. You got refugee populations, migrants, very different levels of education and access. Is your platform or others you're seeing are able to sort of cross that divide, and what's needed, particularly for those very vulnerable populations?
Yeah, I think also telemedicine is very interesting in that sense, right? Because telemedicine crosses the kind of the political divide, the conflict divide, the country divide, and also it kind of gives this equality to access. So as a patient sitting in for example, my home city in Libya, Homs, I can see the best physician in MGH or Johns Hopkins or all these kind of great places, right? Just via access to my mobile phone, and if that physician is already on the platform. So that kind of tremendously eases access. When you talk about internally displaced or IDPs, Libya's obviously like the numbers are crazy. Like we're reaching about like 300,000 internally displaced population because of the conflict, and over 700,000 refugees and migrants. And the way that we're approaching this, again, within the mission of Speetar, is we provide language and culture match specialist care. And to many of these communities, we connect with physicians from their own countries. So we have many of the refugees from sub-Saharan Africa, and we engage them and tell them we have these populations who are unfortunately in detention centers or in kind of refugee camps, and we want you kind of to reach out to them and help them, because especially when you talk about mental health, it's easier when it's delivered by someone who understands your context and language. So we're definitely doing that, and that's one of the main missions of Speetar.
Yeah, it seems certainly meeting patients where they are, having the right culture, language, and form factor is important. And Wendy, certainly, is Spanish a barrier when you want to pull in a physician or specialist from the mainland, and maybe given some of your very disparate populations from the big cities and beyond, how have you seen different formats of telemedicine work or not work?
In my opinion, Spanish is the main language here, and since education in medicine is in English, many physicians and providers here in Puerto Rico speak both languages. Regarding the regulation, we have the same as in the United States. So the flexibility granted on February by the government enhanced the scope of our programs and helped a lot federally qualified health centers and rural clinics to open their services and reach out. The other thing is that our government has been has been very, very specific on how to not let people without the physician services. So they go over the regulation in the States and gave us more space to work, including a lot of other providers of healthcare to participate in this telemedicine effort. They also, the insurance commissioner also issued a letter to oblige the payers or the insurance companies to pay for this type of service as it's want to present, the same fee that is a face-to-face visit in an office.
Yeah, it's certainly accelerated. I mean, COVID has been said to accelerate telehealth and virtual care by over 1,000%, and that the genie may be out of the bottle, and hopefully many of the changes, whether it's relaxing HIPAA or how we do licensing or the payment models will continue. Sticking on the theme of COVID and public health, we often think about telemedicine as I've got an acute problem or a chronic one, I can manage it. But for Wendy first, and then Mohammed, how might we use the data coming in and sort of start to leverage, whether it's virtual public health workers or contact tracers or new data epidemiologically to tie into telehealth for the proactive public health side of the equation, and also to help prevent future pandemics?
Okay, well, we have a very strong contact tracing program going on. It was developed by one epidemiologist that lives in the mountains area. And she has been very active, including municipalities and mayors to participate with her in this effort. Besides that, I think that having a lot of more information, scientific data, which is one of the main problems here, but now with these new programs that we established, I think that we will be more efficient in directing services and to address real healthcare needs of the population. If we do not have that access to data, we will be, doing things with no results. Plus, we included a distance learning curriculum in our telemed program. So we will be using this communication technology to reach out for students and general community in certain areas and topics to build up resilience and to be ready for the next disasters.
Mohammed, what's on your wish list, and how do you see data being used on the public?
I think data is very essential. I think as Speetar, in our essence, we're a data kind of collection platform. And the notion here is we try to integrate with all these local players, whether it's clinics, pharmacies, labs, and try to help them coordinate the data kind of transfer between them, upload results, electronic prescription. But there's something that we were very kind of cautious about from the beginning is this notion of not falling into kind of data exploitation. Again, with many of the healthcare or even non-health solutions that get deployed in developing context, usually there's less regard for where this data is being collected, how it's stored, who's managing it, who does have access to it. And for us from the beginning, we were very cautious about kind of abiding by the global standards when it comes to data protection and working with our partners in Libya, making sure we have all the checks and balances and regulatory oversight when it comes to kind of managing this data. Because I think it's very important down the line. And I think that it's a gold mine, right? Because when you talk about Libya, the data that we're collecting is unprecedented. Like before, everything was on paper and on papers and files. If you would ask a patient, the best patient will bring you a file of like a dozen papers and labs from various years. But now we're collecting all this electronically and are able to kind of gain insights into what's going on, what are the trends, both on the individual level as well as on the population level. And when it comes to kind of predicting pandemics, precision medicine, allocating resources, this is the most valuable thing you can have. Just to understand, like with the platform that we have now, the COVID-19, Speetar COVID-19, we are able to predict future outbreaks. Now we have one in the south, which we knew it was going to happen a few weeks back, just based on who's basically reporting symptoms, right? Because before people test positive, usually they have some kind of symptoms. And if many people within the certain area are reporting symptoms, you have to understand that there's something wrong going on there. And whether I think it's this pandemic or future pandemics, it's keeping an eye on those trends and just gaining insight and implementing machine learning, artificial intelligence algorithms to just know in advance if there's something wrong and how can you react in advance and fast.
Right. I think no clinician necessarily wants more data. They don't want all the raw data from a Fitbit or a blood pressure device, but the insights and the meaning that's synthesized and can be, again, used proactively. So we just have a few minutes left. Some questions have come in. One from Dr. Krishma Vihan. What do you see as the future of telemedicine? Is it and what other maybe products might be integrating in? And maybe I'll ask both of you, what's on your wish list that you hope inventors, innovators might build that would augment your platforms in the future?
I would like to see new policies on paying for telecare. There are a lot of equipment and devices that can help us monitor a patient's progress or to avoid complications. So more than telemedicine only or telehealth, we want to start seeing telecare options, viable options.
Yeah, I think I definitely will build up on what Wendy said. I think whatever needs to be developed is already kind of in development now, and people are thinking about it. I think it's not more about devices at the moment as more as what I mentioned, just kind of making sense of all the data is being collected. Like as I mentioned in the US, in Libya, there's no data before, but in the US, we have these clusters of data that has been kind of building up over the past decades. And now it's up to all these EMR systems into understanding what's going on and kind of trying to work together to glean insights. I think what I would like to see is some kind of form of a global triaging or a chatbot system where a patient in the rural areas in south of Libya will be able to kind of be triaged and get the same level of care that they would get in the most advanced hospitals in any other place in the world.
Yeah, we certainly live now in a global meets local world, and certainly the pandemic has cross-connected us in new ways. And you could imagine the future of telehealth and telemedicine and global health would be creating sort of potentially global collaborative platforms that enable the data, the care, the clinicians to interact anywhere virtually, just as we're doing now, and to bring not just the data but the insights. I like to call it sort of the Google Maps or Waze of health and medicine. So something learned in Puerto Rico or Libya or California or Wuhan, China, all kind of cross connects and can build those better systems collaboratively. So we just have about 2 minutes left. I'd maybe just ask you if you have any kind of closing thoughts, any other, again, lessons that you have both for clinicians, policymakers, technologists, patients, and for the broader Aspen and global community. Wendy?
I'd like to.
I think that, sorry.
No, go ahead, Wendy, please.
Okay, I think that we are, for the first time, I have seen how good the telemedicine is for managing mental health issues. We were under heavy pressure during these 3 years, and by having this modality, I think that people have been taking a lot of benefits that before they were not present. So in my opinion, we need to see the person as a whole, and this service must include both behavioral and clinical efforts.
I think on my end, I would just like to kind of close by a quote I often reflect on by the American-Canadian writer William Gibson. He said, "The future is already here. It's just not evenly distributed." And I think it's up to us to take all these technologies and advancement in healthcare and just kind of make them accessible to people all over the world. And I just want to acknowledge our team, our partners in Libya and abroad who are helping us kind of do that, starting from Libya and hopefully within the region.
Thank you. I love that quote. Again, the future is here. It's a matter of connecting the dots and aligning the incentives and really reimagining health medicine, telemedicine on a global level. So thank you very much, Wendy, for all you've done in Puerto Rico and beyond, and Mohamed for the innovations you're building in Libya and across connections. And thanks to everybody who's joined us online. I'll hand it over to the Aspen team to close us out. Thanks.
Thank you. Thank you again, Dr. Kraft, Dr. Aburawi, and Dr. Matos. We hope that you'll all consider taking action today to support the important work of these leaders. You can see some actions on the screen right now. Please also go to aspenhealthforall.org for more content on the global response to COVID-19, to find their websites and learn more about Aspen Health for All in tomorrow's newsletter. Please be sure to stay in touch, sign up for future conversation, and use the hashtag Aspen Health for All on all social media. Thank you.